Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can provide a comprehensive review of delusional disorder. So I'll take a look at the characteristics of this disorder, and I'll also talk about this controversy between the definitions of delusional disorder and schizophrenia. Now, a delusion is a false belief based on incorrect inference about external reality that is firmly sustained despite what almost everyone else believes and despite what constitutes incontrovertible and obvious proof or evidence to the contrary. The belief is not one ordinarily accepted by other members of the person's culture or subculture. So when I talk about a delusion in the context of delusional disorder or schizophrenia or any other disorder that has delusions, that's what we're talking about here. It's a false belief that does not tend to change. So as we look at the definition of delusional disorder in the DSM, we see that it has criteria A through E, so 5 criteria. The first one, here we see a presence of one or more delusions with a duration of 1 month or longer. So in situations where we see a duration shorter than 1 month, counselors may consider something like brief psychotic disorder, and there are other potential diagnoses, of course, but we would exclude delusional disorder, so that 1 month is in there as a duration. The second criterion is that the first criterion for schizophrenia has never been met. So let's take a quick look at that first criterion of schizophrenia that's referenced here. This requires that 2 or more of the following symptoms are present for a significant portion of time during a 1 month period. We see delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. One of the symptoms must be delusions, hallucinations, or disorganized speech. Another way of putting that is if somebody only has grossly disorganized behavior and negative symptoms, they won't fulfill the requirements for that criterion. So again, now looking at delusional disorder, the first criterion of schizophrenia has never been met. So if a client met that criterion for schizophrenia 30 years ago, they could not get a diagnosis of delusional disorder today. Now, continuing with the symptoms of delusional disorder, the third criterion here, other than the effect of the delusion itself, functioning is not markedly impaired, and the person's behavior is not odd or bizarre. So it's important to point out here that the delusion can be odd or bizarre, but the behavior cannot. And often we do see odd and bizarre delusions with delusional disorder. The fourth criterion, if the individual has experienced major depressive episodes or manic episodes, those episodes have been brief in comparison to the symptoms of delusional disorder. So what they're really saying here is that major mood disorders could explain some symptoms, so the clinician has to be careful with the diagnosing if those major mood disorders are present. Then we see the last criterion, the symptoms can't be better explained by another mental disorder or a medical condition. Now, this disorder also has subtypes and specifiers. When a disorder has subtypes, one of those subtypes, and only one, must be assigned as part of that diagnosis. A specifier is different. It's optional, and more than one specifier can be assigned. So looking at the subtypes, we see that for delusional disorder, there are 7. The first one is erotomanic. So here the central theme of the delusion is that the person believes another person is in love with them. Often the other person has high status, like they might be a celebrity, and the person with the disorder usually tries to make contact. This one can be dangerous under certain circumstances. The next subtype, grandiose. Someone believes that they made a great discovery or they have a special talent. They may believe that they occupy a position that they do not occupy, like they might think they're a movie star, or an alien from another planet, or an elected official. The next type is jealous. This one's fairly straightforward. They believe that their romantic partner is unfaithful. Now again, this is at a delusional level, so the evidence doesn't support that the partner is unfaithful. The next subtype is persecutory, so they believe that someone or a group is trying to harm, follow, harass, or spy on them. This type is often associated with believing in several conspiracy theories. The next type is somatic. Here we see this is really based on bodily sensations and functions. So we could see delusions like someone believing that there's an infestation of insects on or under their skin. This is also associated with substance use disorder, so it's important to differentiate there. They may believe that certain parts of their body are ugly or distorted, or they may believe that they're putting off a foul odor. Again, something connected with bodily functions and sensations. Now, the last two are mixed and unspecified. So with mixed, we see a combination of two or more of the other delusion types. And with unspecified, we see delusions that don't fall into one of those categories clearly. For example, a delusion of reference, where somebody believes that external events are somehow related to them. For example, the person may be watching television and see some sort of event in a far-off country and believe that it's somehow related to them. Maybe they caused that event by what they were thinking or by their mood, like they were feeling depressed that day and that caused like a disaster somewhere else. Another one that's not really captured by the other types is thought broadcasting, so that could be considered unspecified, and that's when somebody believes that their thoughts can be heard by everybody. So everywhere they go, they believe that people are really reading their mind, right? So it's like an invasion of privacy type of delusion. Now with the specifiers, we see this one with bizarre content. So delusions are bizarre when they are clearly impossible, not understandable, and not derived from ordinary life experience. So being chased by the CIA would not be considered bizarre, right, if somebody had that delusion. But if they believe that they are an alien that had a job to visit planets and warn the populations about the dangers of romance novels, that would likely be considered as bizarre. There are also specifiers that capture if it's a first episode or multiple episodes, whether it's an acute episode, whether it's in partial or full remission, and specifiers around the severity. Delusional disorder was introduced in the DSM-3R in 1987, and it's in the ICD-10, although in the ICD-10 it's referred to as persistent delusional disorder. The two disorders are essentially the same. The difference between them is really with the chronological criterion. Again, it's 1 month for the DSM. The symptoms have to be present for at least 1 month, and it's 3 months with the ICD. It essentially doesn't matter because in the real world, delusional disorder tends to persist for a long time. So we're not going to see a lot of people diagnosed with delusional disorder under the DSM criteria that would be missed under the ICD criteria. The prevalence of delusional disorder is between 0.03 and 0.18% in the general population and between 0.4 and 4% in hospitalized populations. The most common type is persecutory. So as we can see, this disorder is rare. And anytime a disorder is rare, there's going to be a little bit of controversy around it, and delusional disorder is no exception. Looking at the criteria for delusional disorder, there seems to be this difficulty distinguishing the disorder from schizophrenia. That's specifically mentioned in criterion B, the second criterion for delusional disorder, as I indicated before. So we see that this is a common complaint among clinicians who encounter a number of psychotic behaviors. This dilemma actually goes back many years. Delusional disorder came out of the concept of paranoia, and some early theorists believed that extreme paranoia was essentially the same thing as schizophrenia, which is interesting because, of course, paranoia is connected to several other disorders, including major mood disorders. Either way, many clinicians don't believe that delusional disorder is a useful diagnosis because, again, they think it's the same thing as schizophrenia. So what does the research say about this? Should delusional disorder be a separate diagnostic classification? Well, by definition, schizophrenia is polysymptomatic and delusional disorder is monosymptomatic. So again, with schizophrenia, we have those 5 potential symptoms we see in the first criterion for the disorder, and somebody needs to have 2 or more. I talked about that before, so polysymptomatic. And with delusional disorder, we only see delusions. We don't see negative symptoms and some of the other symptoms of schizophrenia. There are some key differences across many characteristics according to what we see in a study that looked at 2 groups. One group contained participants with schizophrenia, and another group contained participants with delusional disorder. Participants with delusional disorder tended to develop their symptoms much later than those with schizophrenia. The average age of onset for delusional disorder was 46 compared to 35 with schizophrenia. Participants with delusional disorder are more likely to have experienced a disruption in their family history before the age of 15, like the death of one or both of their parents, a divorce, a separation, or one or both of their parents having a substance use disorder. Now, one of the criticisms of delusional disorder is that when somebody gets the diagnosis, often they are diagnosed at a later time as having schizophrenia or schizoaffective disorder, a disorder that essentially combines the features of schizophrenia with bipolar disorder. Interestingly, though, in this study, 78% of the participants with delusional disorder did not have a shift in diagnosis for a period of 10 years. That's what was looked at in the study. Of those that did have a shift, all of them were male. So it would appear that delusional disorder has a higher diagnostic stability for females. Now, just to put some context around this level of stability, the 78% over a period of 10 years, delusional disorder with this level would be more stable than brief psychotic disorder, more stable than schizoaffective disorder, and equally as stable as schizophrenia. Some other differences between the disorders: participants with delusional disorder had fewer symptoms of anxiety and depression. They were more likely to be living independently and more likely to be working. They took less medication, and they were less frequently hospitalized. They were also less likely to have relatives with a history of psychosis. Here we see the suggestion that maybe delusional disorder comes more from the environment as compared to schizophrenia. One of the things that I've noticed from my clinical experience as a counselor is that if psychosis can't be explained by something like a major mood disorder or substance use, schizophrenia really tends to come to mind for a number of counselors. Disorders like delusional disorder, or for that matter, brief psychotic disorder, are often really not considered. Mental health clinicians are typically familiar with the definition of schizophrenia. So if they see a delusion, they really expect to see other symptoms of schizophrenia, like flat affect, disorganized speech, or hallucinations. So if there's any hint of a symptom like that, clinicians tend to grab onto that as indicating schizophrenia. So it's really like confirmation bias. They may be looking at a client who's not very expressive or maintains kind of a flat expression when they're thinking, and the counselor may say, well, there it is. We have flat affect, negative symptoms, moving right to schizophrenia and bypassing delusional disorder. When considering how delusional disorder does have different associated characteristics than schizophrenia, it's important to assign the correct diagnosis. I can understand the argument if two diagnoses have no differences in terms of treatment, etiology, symptoms, or course. What's the point of a classification if it offers nothing above and beyond another similar classification? However, in the case of delusional disorder, not only is the course different, it's less severe, but the etiology may be different as well, meaning what causes the disorder may be different. There could also be differences around treatment. For example, the absence of negative symptoms may change what type of group therapy would be suggested for somebody with delusional disorder as compared to somebody with schizophrenia. So the controversy around delusional disorder and schizophrenia reminds clinicians to carefully weigh all diagnostic options before making a diagnosis and be willing to consider that a diagnostic mistake could have happened in the past. Some clients who currently have a diagnosis of schizophrenia may actually have delusional disorder. So there's my comprehensive review of delusional disorder, an often overlooked but interesting disorder. I know whenever I talk about topics like delusional disorder, there will be a variety of opinions. Please put any opinions and thoughts in the comments section. They always generate an interesting dialogue. As always, I hope you found my analysis of this topic to be interesting. Thanks for watching.